que tenemos de la Asociación Colombiana de Ginecólogos Oncólogos, con un poquito de delay. Y para quienes no hablan inglés, tenemos en las barras de tareas abajo interpretación. Ahí pueden escoger el lenguaje en el que quieren escuchar la presentación. Es para mí un honor y un privilegio presentar al doctor Ramesh Eskander, ampliamente conocido por todos. El doctor Ramesh Eskander es ginecólogo, oncólogo, es assistant professor en UC San Diego Health, es autor de 95 publicaciones en peer-reviewed journals y es uno de los líderes de opinión en los Estados Unidos. El doctor Ramesh Eskander nos va a acompañar esta noche con la charla de pembrolizumab más quimioterapia en carcinoma de endometrio avanzado. Dr. Eskander, the podium is yours. Thank you so much for accepting our invitation.
Thank you. Gracias, Dr. Pareja. Y también gracias por la amable invitación. Yo me espero la próxima vez estar en persona, pero vamos a ver.
Será un placer.
Thank you so much. Thank you. I wish I could give the presentation in Spanish, but I know it would be terrible. So I will do it in English, and I ask for your forgiveness and understanding. So I think what we've realized over the last several years is that endometrial cancer was a forgotten malignancy for a long time. And we had a period where we neglected to think critically about how we would identify effective treatment strategies for the care of patients with endometrial cancer. And that's reflected in the fact that for over 30 years, the last approval in the United States, at least, was Megace in 1972. But we know that there are over 66,000 new cases anticipated in the year 2023 in the United States, 13,000 deaths, and about 1/3 of these patients will have high-grade or metastatic disease at diagnosis with poor outcomes. And what we also know is that by 2040, it is anticipated that endometrial cancer will be the 3rd leading cancer in women and the 4th leading cause of cancer death. And this is not just a United States problem, it's a global problem and an issue we are facing together. And we also know that there are important disparities in outcome, and it's unclear why. We can't attribute this only to high-grade or advanced stage disease, but we know that mortality rates in African American or Black women is significantly higher than it is in white women, even when we control for histology and stage. And there are reasons biologically that we have yet to define. And this is an important area as we try to close the disparity so we can have similar cancer outcomes. And that's very important for us. This table summarizes the evolution of care, systemic therapy, in patients with advanced stage or recurrent disease. You can see with Gynecologic Oncology Group Protocol 122, we went from whole abdominal radiation to systemic chemotherapy with doxorubicin and cisplatin. And then we tested various single agents and doublets against one another until ultimately Dr. Miller, on behalf of the GOG, helped show non-inferiority of carboplatin and paclitaxel to the prior triplet regimen of cisplatin, paclitaxel, and doxorubicin. And importantly, carboplatin and paclitaxel was more well tolerated by patients. So that really emerged as what we call the chemotherapy backbone, the standard of care regimen for patients with advanced stage or recurrent disease. But we have so much left to accomplish. Why? As we see illustrated in this table, if we look at prior phase 2 and 3 studies with over 1,800 patients, we see that the response rates to alternate treatments was quite modest. Response rates of 5%, 10%, duration of response quite limited. And this really highlights the unmet medical need, meaning more drug discovery is needed to inform outcomes for this patient population. Briefly, I want to talk about GOG Protocol 209. This is what gave us carboplatin and paclitaxel. Importantly, these patients were randomized to trial. They had to have advanced stage disease, but they were not mandated to have measurable disease. No prior adjuvant therapy was permitted, and they were randomized to carboplatin and paclitaxel or the triplet regimen of cisplatin, paclitaxel, and doxorubicin with GCSF support. And as you guys are aware, advanced stage disease, of course, prior to this was managed with the triplet regimen. No mandate for measurable disease was required, no prior cytotoxic chemotherapy was permitted. And as we saw in the publication in JCO in 2020, the survival curves completely overlap. So carboplatin and paclitaxel was essentially identical to the 3 chemotherapy regimen, non-inferior based on the statistical assumptions of the trial, with improved quality of life and tolerability. And so carboplatin and paclitaxel emerged as our preferred regimen. But thankfully, we have had significant gains since GOG 209. And why? Because we have gone from the light microscope, just looking at pathology, depth of invasion, LVSI, and we've gone to the molecular microscope, where we're now starting to think about what is the molecular characterization of the tumor to inform effective treatment strategies. GOG 209 did not have any molecular characterization. All of these endometrial cancer patients were treated identically. And we know now that we can't necessarily design clinical trials that way and expect positive outcomes. And as we know, the seminal TCGA publication from 2012 divided endometrial cancer into 4 distinct molecular subgroups. The POL-E ultra-mutated, incredibly high tumor mutational burden, and exquisitely sensitive to immunotherapy. The MSI high or mismatch repair deficient, hypermutated, again, elevated TMB, sensitive to immunotherapy. But then we had these 2 other cohorts, the copy number low or the no specific molecular subgroup, and the copy number high P53 serous-like histologies. And we've taken this information and we've really started to think about how is this impacting our management? As some of you may be aware, just again, this week in JCO or last week, they published responses from PORTEC-2 and PORTEC study looking at the impact of molecular characterization on benefit to radiation. And so we're continuing to evolve our understanding of how these molecular characteristics may inform treatment strategies. And just like I summarized on the prior slide, here we see the relevance of these molecular subgroups. And on the right side, we see the potential therapeutic treatment strategies that apply to each cohort of patient. And I will tell you that in the copy number low and in the copy number high is where we have the greatest room for improvement. We don't know if there's a cohort of these patients that needs CDK4/6 with hormonal therapy. We don't know if there's a component of these patients that will benefit from P53 targeting nuclear export drugs like Siendo in the Karyopharm trial. We don't know if there's a proportion that will benefit from WEE1 targeting agents, cell cycle disruption, HER2 targeting therapy, which we're going to review briefly here. But this slide summarizes areas of active investigation. There have been publications that suggest P53 mutations portend a response to anti-angiogenic treatment. And that was shown in an ancillary data translational research project from GOG 86P, that bevacizumab with carboplatin and paclitaxel appear to be superior to carboplatin and paclitaxel alone in P53 mutated, copy number high patients. Anti-HER2, we have in the United States, trastuzumab is NCCN compendium listed with carboplatin and paclitaxel in HER2 amplified, IHC 3+, or if it's 2+, confirmed by in situ hybridization in the primary metastatic or recurrent setting. But now we've opened that door. Why? Because we have a publication from the cohort in Japan, 7 institutions showing really dramatic efficacy in carcinosarcomas pre-treated that were HER2 low even by IHC 1+, 2+, and 3+. And then the ASCO Pan-Destiny 02 trial, which showed a dramatic response rate, which we'll highlight separately. WEE1 inhibition is showing promise. There's azenosertib is one WEE1 inhibitor under active study. Adavosertib, which was an AstraZeneca drug, was examined. Unfortunately, we've had a difficult time dosing these drugs because of treatment-related adverse events. So there's more that we need to do. And then I mentioned hormonal therapy adopted from breast cancer in the P53 wild type, estrogen receptor positive, copy number low patients. Is there a space for CDK4/6 and hormonal therapy? That was studied in the Paleo trial and also in the letrozole and abemaciclib study by Panos Konstantinopoulos from Dana-Farber. Just briefly, I want to highlight the utility of anti-HER2 therapy. So this was a study, randomized clinical trial led by Amanda Nichols-Fader and colleagues at Hopkins, and alternate institutions enrolled patients with advanced stage or recurrent disease, HER2 positive 3+ by IHC, or if 2+ positive by in situ hybridization, and compared carboplatin and paclitaxel versus carboplatin, paclitaxel, and trastuzumab. And we can see that there was a significant benefit in the primary efficacy assessment of progression-free survival. But this was a non-blinded study, and it was a phase 2 trial. So there was concern that the investigators may bias the efficacy assessment response. And what they saw additionally was the magnitude of benefit appeared to be almost universally driven in the chemotherapy naive advanced stage patient. And you can see that on the left panel on the slide, where the median PFS was 17.9 versus 9.3 months. And importantly, in Clinical Cancer Research in 2020, when they published the updated overall survival data, we see that the benefit again appeared to be most dramatic in the chemotherapy naive patients. And although there was question about the PFS benefit because it was an unblinded investigator assessed trial, overall survival was a more definitive endpoint, and we still saw an advantage, and this had NCCN compendium listing. But importantly, there's still some controversy. Should we use breast staining for HER2? Should we use gastric basolateral staining for HER2? What should be the cutoff? What are the expression levels? And you can see that depending on what we're using to define positivity, the expression level can vary dramatically. And this ties directly into the PanDestiny-02 trial, which was presented at ASCO, looking at an antibody drug conjugate, trastuzumab deruxtecan. So it's an anti-HER2 monoclonal antibody, and importantly, it has a topoisomerase 1 payload with a cleavable linker. And this was a multi-cohort study looking at several solid tumors, but I want to focus on the endometrial. 40 patients with previously treated endometrial cancer were enrolled on this trial. Importantly, 35% were ongoing treatment at the data cutoff, and the median duration of response was not reached for many of these patients. The objective response rate in a previously treated endometrial cancer patient population, HER2 adjudicated by local IHC, they had to be 2+ or 3+ to enroll, was 57.5%, which is much higher than what we'd expect based on historical controls. And the median duration of response was not reached in the endometrial cancer population. And quite dramatically, if you look at the HER2 3+, the response rate that was confirmed was nearly 85%, 47% for 2+. And when they did central testing, they actually identified that some of these patients were not 2+ or 3+, they were 0+ or 1+. And we still saw this benefit. And so I bring this up to say that, we are evolving. There's multiple opportunities for treatment efficacy. And this was the paper that was published in JCO in 2023, March, Nishikawa, looking at carcinosarcomas, IHC 1+, 2+, or 3+, with objective response rates that were confirmed measuring from 50 to 70%. Look at the waterfall plots. Nearly every patient had a reduction in tumor volume, which is dramatic. So we are incredibly excited about what this may offer us as well. And in fact, in the United States, we are already using this drug for the treatment of HER2 positive disease in appropriately selected patients who have recurrent disease. Again, these are all recurrent pretreated patients. And there's a prospective randomized clinical trial right now that's asking this question, even in early stage 1 and 2 endometrial cancer. It's NRG-GY026 that's led by my colleague Brick Erickson at the University of Minnesota. There's some concern about whether the control arm is the right control arm because of the data that we're going to talk about with pembrolizumab and endometrial cancer, but nonetheless, this is an active and accruing study. I don't want to spend too much time on this. This is the WEE1 inhibitor adavosertib, looking to capitalize on replication repair stress, because in P53 mutated endometrial cancer, there's a dependence on the G2M checkpoint, and WEE1 is responsible for that. And if you inhibit WEE1, you can drive replicative stress and lead to cancer cell death. And this was looking at adavosertib as a single agent in recurrent endometrial cancer. And what we saw was an objective response rate by BICR of about 26%. So better than some historical chemotherapy controls, but the disease-related toxicity was too high. So now I want to pivot to the immunotherapy. Immunotherapy has transformed our treatment of many solid tumors. Here we leverage this idea of mismatch repair deficiency. Whether you have hereditary acquired Lynch syndrome or you have somatic mutations in the tumor or epigenetic silencing, when you have dysfunctional mismatch repair, you get single base mismatches, you get short insertions and deletions, and these result in neoantigens and accumulation of mutations, which then lead to a phenotype that's suggestive of response to immunotherapy. And this happens over time. We know from the Keynote 158 study, which really gave us a disease site agnostic approval in the United States, that pembrolizumab monotherapy was exquisitely effective in mismatch repair deficient endometrial cancer cohorts. You will remember that Keynote 158 included multiple disease sites. The second largest to colorectal was the endometrial, and the objective response rate here initially reported 57%, median duration of response not reached. These were numbers that we couldn't believe when they were initially reported. And we know also in the same breath that in the biomarker negative mismatch repair proficient patients, that immunotherapy by itself is ineffective, response rates of 5 to 10%. So we have these studies that show the relevance of the biomarker, but we also have a large population of biomarker negative patients. And these are the studies that summarize the efficacy in the biomarker positive dMMR population, where we see dramatic response rates approaching 50%. In an effort to improve outcomes in the biomarker negative P, mismatch repair proficient patient population, Vicky Macker led Keynote 775, and this looked at lenvatinib, a multi-tyrosine kinase inhibitor, with pembrolizumab versus physician's choice chemo, which was doxorubicin or paclitaxel, because this is recurrent after prior carboplatin and paclitaxel. And the theory here was that the tyrosine kinase inhibitor alone, which had a response rate of about 14% when studied as a single agent in a phase 2 trial in endometrial cancer, and pembro, which had a response rate of about 12% in the pMMR, when put together would synergize, and we would get a more robust response rate. The primary endpoints were progression-free survival and overall survival, co-primary endpoints. And what we saw here was a statistically significant and clinically meaningful improvement in both progression-free survival in the pMMR cohort, nearly doubled from 3.8 to 6.6 months. And you can see the curves separate, and they preserve their separation, which drives the hazard ratio, which was 0.6, 40% reduction in the risk of disease progression or death. And importantly, a meaningful and statistically significant improvement in overall survival, 12 months to 17.4, again, hazard ratio of 0.68. This led, after we had an accelerated approval following the prior study, Keynote 775 resulted in full approval of this combination in the United States. And we know with longer follow-up in the pMMR population, the clinical benefit persists with respect to survival. 12.2 months for physician's choice chemo, 18 months for lenvatinib and pembro. And again, that's despite crossover, which happened in these arms. Now, there has been some discussion about, in the mismatch repair deficient patients, does the mechanism of loss impact response? Meaning, if you have a mutation versus you have an epigenetic silencing via promoter hypermethylation, does this impact how the patient responds to immunotherapy? And this was looked at as a retrospective assessment in the Garnett trial. And what they saw was that the route to mismatch repair loss, whether it's mutation or epigenetic silencing, did not appear to impact response. 39.4 versus 42.9% objective response rate. Now here, they didn't specifically look at promoter hypermethylation. They looked at loss by IHC and no mutation as a surrogate for MLH hypermethylation. But I will tell you that this remains controversial because there are other studies that suggest that epigenetic silencing does not lead to as robust a response to single agent immunotherapy. So now we come to what I would consider the most recent data that has really evolved our treatment paradigm for endometrial cancer. In several other solid tumors, immunotherapy and chemotherapy have been shown to synergize and result in improved efficacy responses. Why? Because chemotherapy can have several immunogenic effects. It can lead to cytotoxic cell death, increase in neoantigens, a decrease in regulatory T cells, and a decrease in myeloid-derived suppressor cells. So if we combine chemotherapy with immunotherapy in patients who have metastatic disease, can we improve cancer outcomes. And this was examined in several trials, 2 of which have reported out, and I will review with you. The first, RUBY or GOG3031, this looked at the checkpoint dostarlimab with carboplatin and paclitaxel versus placebo with carboplatin and paclitaxel. It allowed carcinosarcomas, but capped it at just 10%. It allowed some patients who had periortic positive, completely resected 3C2 disease to enroll. But I will tell you, the vast majority of patients on this trial were enrolled with measurable or recurrent disease. Patients were treated with maintenance dostarlimab for up to 3 years, and the statistical analysis was hierarchical. They first looked at the benefit in the dMMR population and then in all comers. That was where the alpha was applied. There was an intent to do an exploratory examination in the pMMR, but it was not alpha tested. You can see here the patient characteristics were as you would anticipate for this cohort in terms of recurrent metastatic endometrial cancer. And the transformative data was presented, published in March of 2023, concurrent with the presentation in the New England Journal of Medicine. In the dMMR population, a dramatic reduction in the risk of disease progression or death, hazard ratio of 0.3. If you look at these curves, I don't think we could ask for a more dramatic improvement in clinical outcomes, suggesting the benefit of immunotherapy in addition to chemo in this patient population. In the all-comers, when you looked at dMMR and pMMR together, hazard ratio of 0.64, still statistically significant. But of course, the question was, we want to know also overall survival. And despite crossover, 38% crossover in the placebo arm, there still appears to be a significant benefit in overall survival with incorporation of immunotherapy and chemotherapy in dMMR and in the intent to treat overall population. Again, this was exploratory. RUBY was not intended to or powered to answer the pMMR, and what you saw was a signal and improvement in PFS and a signal towards a numerical improvement in overall survival in the pMMR cohort specifically, hazard ratio of 0.76 and 0.73 respectively. And again, crossover occurred in 33% on the placebo arm. And thankfully, there were no new safety signals when you compared it to prior immunotherapy and prior chemotherapy trials, which was quite important for us. And then here we'll talk about GY018. Similar trial, pembrolizumab with chemo, followed by pembrolizumab maintenance or placebo chemo, placebo maintenance. Advanced stage, metastatic or recurrent disease. If it was advanced stage at diagnosis, they had to have measurable disease at enrollment. They were allowed prior chemotherapy as long as it was at least 12 months. And I will just mention, this trial was designed with 2 independent patient populations, dMMR and pMMR, each one powered and statistically tested independently. And you can see again here, you see the 2 cohorts, 225 dMMR patients, 588 pMMR patients. And you can see that the majority of patients in the dMMR mismatch repair deficient cohort were endometrioid histology. But in the pMMR population, we had 25% serous, nearly 5% clear cell, and we had some dedifferentiated. So an aggressive cohort. 25% of these patients had prior adjuvant therapy and then recurred 12 months after that adjuvant therapy. And we can see here again in the dMMR population, a dramatic improvement, 70% reduction in the risk of disease progression or death, hazard ratio of 0.3. But what really surprised us, in all honesty, was the hazard ratio in the independently powered pMMR cohort, where we saw the tails of these curves, they separate and they remain divergent, with a tail at nearly 40%, which is really a dramatic improvement compared to other studies in an advanced stage recurrent population. And the hazard ratio was 0.54, 46% reduction in the risk of disease progression or death. And thankfully, again, these tornado plots show that the regimens were well tolerated, no new safety signals with incorporation of immunotherapy plus chemotherapy, pembrolizumab plus carboplatin and paclitaxel in these patient populations. And when we looked specifically at immune-related adverse events, no concerning signals, again, highlighting the safety of this regimen and the clinical efficacy. Some of you may have seen this paper, which was published in Lancet Oncology, MITO N3. This was a very small study. You can look, 60 patients approximately, And in the pMMR cohort, there appeared to be a worse outcome with immunotherapy when given in combination with carboplatin and paclitaxel. This was an anti-PD-L1, not an anti-PD-1. Avelumab was tested. And I don't think we can make heads or tails of this. It's unclear what the relevance of this data is. And I will just end by saying we have another press release, Duo E, which is looking at olaparib plus durvalumab as maintenance versus durvalumab as maintenance versus placebo, reported positive top-line results. The statistical design of this trial makes it difficult to compare all the arms to each other, but at an upcoming scientific meeting, we are eager to see this data and to see what olaparib in conjunction with durvalumab may add, particularly in the pMMR patient population, where there's a hypothesis that PARP inhibitors may capitalize on an HRD, homologous recombination deficiency signature, in the pMMR patient cohort. And I think here I want to show you the TAPR trial as an illustration of what we think the future is going to be. I think we've moved away from just putting everybody on the same trial. We are now going to go to identify patients who are molecularly distinct, P53 wild type, P53 mutated, HER2 positive by IHC, dMMR, pMMR. And we're going to take each of these cohorts and we're going to thoughtfully develop trials to investigate agents so that we can increase our chances of success. Because at the end of the day, our shared goal is to bring effective therapies to our patients that can really transform their lives, which you have done already in the work that you do by enrolling and treating patients on trial. I know I may have gone over a few minutes. I apologize. And I apologize again that it was in English and not in Spanish. But I really thank you so much for your time. And I'm more than happy to answer any questions you may have about the data that was shared. Thank you so much.
Thank you, Ramesh, for an excellent and very comprehensive and complete presentation on the landscape of advance of endometrial cancer right now. ¿Hay alguna pregunta del auditorio para el doctor Ramesh Eskander? ¿Alguno de los oncólogos que nos acompañan? Ramesh, I have no...
René.
Mark, okay.
Sí.
Dale.
Bueno, yo creo que lo hace en español porque está con traducción. La primera pregunta, yo tengo dos preguntas. La primera es, teniendo en cuenta los datos de la doctora Fade, o sea, el estudio Trans2 Carbo-Pacli, si ahora el problema en primera línea que vamos a tener es cuando tenemos cáncer de endometrio con MMR positivo, es decir, paciente con MMR deficiente y ER2 positivo. Si llegamos a tener esos casos, por ejemplo, con doble trastorno molecular, con ER2 positivo y DMMR, ¿qué hacemos? ¿Le damos primero carbo-pacli Trans2 o le damos mejor carbo-pacli más inmuno? ¿Cuál sería la mejor? Y teniendo en cuenta que Duroxecam va a llegar a primera línea, o sea, en el futuro vamos a tener más problemas todavía cuando tengamos Duroxecam posiblemente en primera línea. ¿Es tratar con inmunoterapia más quimio o tratar con anti-ER2 más quimio?
Yeah, it's an excellent question. So in my mind, if the patient is mismatch repair deficient, then chemotherapy with immunotherapy would be the first line of treatment. So carboplatin, paclitaxel, pembrolizumab, or carboplatin, paclitaxel, dostarlimab. Why? Because if you look at the curves, and all we can do is compare across trials, but if you look at the progression-free survival and the overall survival curves, the benefit of immunotherapy appears to be dramatic. And we are thinking that we are curing more of these patients. That's in the dMMR. So I believe strongly that in the mismatch repair deficient patients, it is an immunotherapy world. Now, of course, some of those patients may still recur. And in those cases, if they're HER2 positive, then anti-HER2 treatment is appropriate. But I think the more confusing area is in the mismatch repair proficient HER2 positive. Then we have maybe chemo and immunotherapy based on 018, and then trastuzumab or trastuzumab deruxtecan or chemotherapy plus trastuzumab. We don't know the answer. And I think we have to conduct the right trial to compare those two if we believe that chemotherapy plus immunotherapy should also be the standard of care in the mismatch repair proficient pMMR patient population.
Perfecto, muchas gracias. La segunda pregunta es esta. Cuando uno mira el estudio Ruby y el estudio Keynote 868, la población, primero, no son tan similares los estudios. Los esquemas puede ser quimio más inmuno, pero hay cosas diferentes en los dos estudios. Primero, por ejemplo, Rubia incluye paciente con carcinosarcoma, mientras el estudio de Pembro no. Segundo, el Ruby, los pacientes ingresan más de 6 meses post-progresión o recaída, mientras Pembro es más de 12 meses. ¿Usted no cree por esa diferencia de 12 meses y 6 meses, porque teniendo en cuenta que los pacientes que tiene una recaída después de 12 meses es más quimiosensible que una paciente que tiene recaída después de 6 meses? ¿No cree que la población del Keynote 868 tiene mejor pronóstico que los pacientes de Ruby? Por eso.
Yeah. Absolutely, it's a possibility. But the key is to look at the control arm. So if you look at the control arm of the two studies, Ruby and GY018, the median progression-free survival in the control arm, chemotherapy alone plus placebo, is almost identical. In the pMMR population, 7.6 months, about 7 to 8 months. So that tells me that these are not more chemosensitive. If they were chemosensitive, they should respond better to carboplatin and paclitaxel as well in the control arm, and they did not. So now, could the longer chemo-free interval of more than 12 months do something to the interaction between chemo and immunotherapy in the pMMR? Maybe. We don't know. But I think when you look at the curves, the Kaplan-Meier progression-free survival curves for GY018 in the pMMR population, you see that the curves, the tails are very different. And the divergence happens shortly after the median, but it's fairly drastic. So we're still trying to make sense of that. I will tell you right now, we're going back to all of the pMMR patients, and we're going to do molecular characterization of all of those to see what is the TMB, what is the HER2 status, what is the P53 status, what is the POL-E mutation status, to see is there drivers of response in the pMMR that we're not aware of just based on the pMMR biomarker alone.
Mark. Okay.
Sí, sí, muchas gracias. Yo tengo otra, pero de hoy para que alguien más, Abraham quiere preguntar.
Abraham, ¿la quieres hacer tú? Okay, we have a question in the chat box. Is there any scenario for giving pembrolizumab as a single agent in first line in patients with DMMR, for instance, ECOG2 or elderly patients?
So repeat that. Is there a role for giving pembrolizumab monotherapy in the first line?
Yeah.
Excellent. As you guys may be aware, there's a study, C93, which is comparing pembrolizumab monotherapy versus carboplatin and paclitaxel in the DMMR patient population, metastatic or recurrent. That study is close to accrual, or I should say is nearing closure to accrual. It's not yet closed, I don't believe. And we will know the answer. I will tell you, my suspicion is, of course, pembrolizumab will be more effective than carboplatin and paclitaxel. The question will be, is pembrolizumab alone equally as effective as carboplatin, paclitaxel, and pembrolizumab, followed by pembrolizumab maintenance? And we're going to be left to compare the studies because we're not going to do a non-inferiority. It would require a big, over 1,000 patient non-inferiority trial, which is not feasible. But I will tell you that in my practice, even now, if I have a patient that may be frail and they're DMMR, I will start with chemotherapy, carboplatin, paclitaxel, and pembro. But if I feel like they're having a very difficult time tolerating the chemo, I am not aggressive about continuing. I will pull back on the chemotherapy to ensure that they stay on the immunotherapy because I feel like that's the most important therapeutic intervention for them.
Okay, thank you very much, Ramesh. Mar, si tienes otra pregunta, es momento de hacerla.
Una de las preguntas que yo quisiera hacerla, sabemos que los tumores son muy heterogéneos, ¿no? Yo puedo tener respuesta en primera línea diferente a la respuesta que puedo tener en segunda línea. ¿Usted está de acuerdo de retestear los tumores a la recaída o hacer nuevo perfil molecular? Como algunas veces yo he hecho, he encontrado cosas totalmente diferentes al tumor inicial. ¿Usted está haciendo eso?
Yes, absolutely. Yeah, we retest, correct. So we're fortunate. We have the ability to do molecular testing on specimens repeatedly in the United States. So we can test the initial specimen, and if the patient recurs, I will frequently biopsy and retest. Because I agree with you, there can be an evolution. We don't have it defined yet across all the different histologies, what the rate is of potential change. But we do see change, and we may identify a marker that is predictive of response to a particular drug. And we don't want to miss that. So yes, absolutely. Retest and rebiopsy is feasible. And in fact, I have had personal experience where the initial biopsy is pMMR, and on recurrence, it's dMMR. Now, is this because there's heterogeneity in the sampling and the area that was sampled initially was not reflective of the tumor? I don't know. But I do think that it's worth it. If you have access to the tissue and it can be biopsied without risk to the patient or without unacceptable risk, I would biopsy to get additional information and use that to guide treatment.
Gracias. Otra pregunta, ¿el PDL1 toma en cuenta el PDL1 para definir algún tratamiento?
Is it PDL1 expression? Is this the question?
Sí,
Yeah.
lo toma en cuenta.
No impact on PDL1 expression in endometrial cancer. We don't believe that there's a correlation. No.
Okay.
Ramesh,
Yes.
although there is not the topic, but I have to ask. The fellows don't forgive me if I'm not asking you this. What are your thoughts on their new FIGO classification?
Oh my God.
A couple of months ago.
We're all in the same boat. It's chaos, Renee. Honestly, I will tell you, we have not yet implemented it in our clinical practice.
Okay.
Because our pathologists, we do HER2, we do MMR IHC, we do P53 on our specimens in the institution. But the most important question is, and this is what I worry about. Usually stage is a stage because it informs adjuvant therapy. So why does stage matter? Because if I have a stage 3C patient, in my mind, I know that 3C warrants adjuvant systemic chemotherapy.
Yeah.
And now that we've revised and we've made serous P53 mutated automatically stage 2, what does that mean? How do we treat this patient? So we've created, I think, I'm worried, we created some confusion because we've changed the stage without defining what the appropriate therapy is in the adjuvant setting. And I think we're all stuck in the same space where, okay, we get it, there's a new stage, but what do I do with this? What do I do with this information? I don't understand how to transform some of it into clinical practice. And even, memorizing the stage, we memorized the last stage, memorizing this stage is, we all gonna need to walk around with a key card so that we can reference the data.
Mi opinión es casi lo mismo, sobre todo esperando los resultados de Rembo. Y yo creo que los resultados de Rembo van a ser positivos y eso va a echar a perder todo lo que hemos hecho en la nueva estadificación. Hubo como un apresuramiento de hacer eso sin esperar el Rembo, porque yo creo que Rembo va a cambiar todo.
Yeah, I agree. But I would have, in my mind, I would have thought we do Rainbow first, we get the results of Rainbow, and then we use that information to revise the staging, knowing the outcome.
Eso.
But we went opposite. We revised the staging, and then now and all of our studies are not none of the studies are using update. Rainbow's not using the new staging, of course. Rainbow's using existing staging because of when it was activated. So we'll see. We'll see what it may revise. I hope they simplify it actually. Right now it's so complex, so complicated.
Probably we'll see a lot of letters coming in the next month.
That's right.
Editorial letters.
That's right.
¿Hay alguna otra pregunta para el doctor Rames Eskander de parte de la audiencia?
Otra cosa, René, como en Colombia no tenemos dostarlimab, es decir, uno a veces dice quisiera hacer más de lo que pudiera hacer. ¿Cuál es la intercambiabilidad? Porque primero no tenemos dostar, tenemos solamente pembro. Si tengo una paciente ahora mismo que recae a los 8 meses, no está para el estudio Keynote 868, o sea, no estaría, sería para Ruby. Pero si yo tengo una paciente que recae, no sé, ¿qué tan intercambiable puedo hacer? O sea, no es comparable los dos estudios, pero no sé qué tan intercambiable puede ser los dos medicamentos teniendo solo en Colombia pembro.
Yeah. I'll be honest. I don't think there's a biologic difference between dostarlimab and pembrolizumab. I think both drugs are very similar. They're similar anti-PD-1s. Ruby and 018, I think the data synergizes, is complementary to each other. And so in my mind, I would use, if you have pembrolizumab, I would use pembrolizumab no differently, as long as you have access and you can use it to treat your patients based on access to the drug. And I would do the same thing here in the States. Some institutions in the United States, they only have pembro on the formulary, no dostarlimab. So we use pembro instead of dostarlimab. It's not a problem in my mind.
Muchas gracias.
Gracias a usted.
Ok, si no hay más preguntas, quisiera agradecer en el nombre de la Asociación Colombiana de Ginecólogos y Oncólogos al doctor Rames Eskander por haber compartido este tiempo de su conocimiento con nosotros. Has been a pleasure having you, Rames, and
Thank you.
hope to having you in person in Colombia in the near future.
I would love it. Thank you so much for having me virtually, you guys. It's wonderful. Thank you.
Thank you very much. Muchas gracias a todos. Buenas noches para
Thank
todos.
you, doctor.
Bye-bye.
Thank you. Bye bye.
Bye-bye.
Gracias a todos.
Muchas
Recuerden